I am Nicole Scovis. I'm a pharmacist by training, and I currently serve as the Senior Director for Pharmacy Practice Innovation at Tabula Rasa Healthcare. My background is really in caring for people with diabetes in primary care and in ambulatory care as part of the healthcare team. And a few years back, after caring with people for diabetes for so long, I became much more interested in the prevention of diabetes. How do we keep these people from needing all of this care with diabetes and instead shift to a preventative approach? And so I was able to start a diabetes prevention program, and I'm thrilled to share with you today the lessons that I've learned and some things that I hope that you will be able to use as you develop your own national diabetes prevention programs. At the conclusion of this session, you should be able to provide an overview of the National Diabetes Prevention Program, as well as to incorporate key steps to building the lifestyle change program, which is really the intervention part of the NDPP. And then also explore opportunities to build on these foundational steps in order to grow the program. So let's jump right in. Starting off with the National Diabetes Prevention Program, a little bit of background. So we know that diabetes is a huge public health challenge. There are 34 million Americans that have diabetes. With the last year of COVID, that number has probably increased. These numbers are from 2020 report. There are another 88 million, so almost 3 times as many people who have prediabetes. So that accounts for about 1 in 3 Americans who have prediabetes. Additionally, 8 in 10 of those people don't know that they have prediabetes. So we've got this huge surge of people right behind the people with diabetes that may go on to develop diabetes, because we know without intervention, people with prediabetes may go on to develop diabetes within 5 years. So we may see that 34 million really surge. Additionally, the healthcare costs of diabetes are pretty significant. So we see that the care of people with type 2 diabetes costs employers and insurers in the billions with a B, and that's every year. So very, very significant costs. And we see that across really the scope of healthcare. So not just the employers and the insurers, but the health systems and the community health centers and the federally qualified health centers. Those costs are really significant portions of those healthcare budgets. People who have diabetes incur on average about $16,000 per year in medical expenses, which is almost 2.5 times of the cost of the care for somebody without diabetes. So as somebody goes from a diagnosis of prediabetes to diabetes, those costs go almost 2.5-fold. And then it's much less expensive to prevent diabetes. So that shouldn't come as any surprise that it's less expensive to prevent diabetes, but we also want to think about not only are we preventing the expense of the care of the person with diabetes, but also the consequences of the disease. So if we can prevent things like blindness and kidney failure and amputations, heart attacks, strokes, that's all part of the costs of the consequences of developing diabetes as well. So we have a lot of opportunity. The good news is that there is a proven program. There's an evidence-based program, the National Diabetes Prevention Program, that is a structured lifestyle intervention program, and it cuts the risk of developing diabetes in half. So it says half on this slide. I'm going to let you in on a little secret. It's actually 58%, which is on one of my later slides. But very significant reductions in development of diabetes for people who participate in this program. The challenge is getting this program out to those 88 million people. And so private-public initiatives are part of the solution for that, to be able to roll that out to the people who need it. So that includes community organizations, private organizations, employers, healthcare organizations, et cetera. Those organizations coming together then help us to reach those 88 million people who really need this program, who we really can see that benefit in. The lifestyle change program, as I mentioned, is the intervention portion of the NDPP. So the NDPP as an umbrella term includes the research, it includes the partnerships. The lifestyle change program is the intervention itself. So just in terms of terminology. The components of the lifestyle change program are these three things that are listed here. A trained lifestyle coach. The coaches have to go through specific training in order to be coaches in this program, and I'll go into that in a little bit more depth. They have to use a CDC approved curriculum for this program. There are 2 approved CDC curricula for the National Diabetes Prevention Program. We're going to focus on the Prevent T2 throughout this presentation, which is the one that's most commonly used and also the one that's been most recently produced. The third component is group support. So it's important for people with prediabetes to be able to share with their peers, to be able to learn with and from their peers as they go on this journey in preventing diabetes. So let's dig into the curriculum a little bit more. The overall goal of the National Diabetes Prevention Program is to help participants make lasting changes in their behavior. And they focus on specifically on healthier eating, increasing activity level, and improved problem solving. So I'll show you how all of those things fit in as we move to the figures below. In the figure on the left here, it shows you the layout of the program. It's a year-long program. The first 6 months is the core phase, and the second 6 months is the maintenance phase. In the core phase, participants meet with their coaches every week and their group every week for these sessions. The core sessions focus on skill building. So it helps to teach participants how to eat healthier, how to increase activity, how to read labels of nutrition labels, how to decide what types of activity count for what level of intensity. So really the building blocks for how to make those changes in their behavior. And also in that core phase is when the participants set goals related to healthier eating, physical activity, as well as weight loss. And then they work through those goals with their coaches to help achieve those goals. In the maintenance phase focuses more on sustainability. So participants meet with their coach and their group at least monthly during the maintenance phase. And these modules focus more on what I call the what ifs. What if I go out to eat? What if my family comes to visit me? What if I'm not feeling motivated anymore? What if I was doing well and I've sort of fallen off of the program, and how do I get restarted again? So it really focuses in the maintenance phase on those problem solving skills. And really the focus at that point is to make sure that they've built these skills that they can then sustain over the period, not only of the program, but beyond. And we'll see some of the results of that as well. In the green box to the right here, you can see some examples of what the modules are in each of these sections. And they do focus on healthy eating, on physical activity, and on weight loss. But notice that they also include things like managing stress and getting enough sleep. These additional, more comprehensive concepts can help participants with overall wellness. And those things can also help them with sustaining those behaviors as well. The participant goal for the program is to lose 5 to 7% of their body weight. So they set those goals in the core phase of the program to lose that 5 to 7% of their body weight, and then work through that through the course of the year with their coach and their group. The weight loss and attendance are the things that are most correlated with the success of the program. So those are the things that really we measure, and we make sure that participants are attending and that they're losing that weight, the 5 to 7% of their body weight. In order to be eligible for the program, people have to either have a diagnosis of prediabetes or they have to be at risk for developing diabetes. So a diagnosis of prediabetes might be from a provider. You also may have lab values that are in the prediabetes range. So an A1C or a fasting blood glucose also qualify somebody on the basis of diabetes. And then the other two that are listed there are conditions that put people at risk for diabetes. So if somebody's had a previous pregnancy where they developed diabetes, gestational diabetes, then they are at risk for developing diabetes later, so they can be eligible for the program. Or you can qualify patients based on the risk test. The CDC has a test called Take the Test, which I will link out later in the presentation. And people who score high risk on that test are also eligible for the NDPP based on their risk of developing diabetes. In addition, participants have to be 18 years or older, and they have to be overweight or obese. So on the previous slide, I mentioned that 5 to 7% of weight loss. So we want to make sure that the people that qualify for the program are eligible to lose 5 to 7% of their body weight. And then in order to participate, people cannot have a diagnosis of diabetes already. If they have a diagnosis of diabetes, it would be more appropriate to refer them for diabetes self-management, education, and support rather than the DPP. And lastly, in order to participate, people cannot be currently pregnant. Weight loss in pregnancy should be medically supervised, so they wouldn't be able to participate until after that pregnancy. The clinical results of the program are astounding. I already gave away the 58% reduction number. In people who are older, that number is even more pronounced. So in those that are 60 or older, we see a 71% reduction in the development of diabetes. So very significant clinical results. I also like to point out the sustainability piece. So remember, the second half of the program, the maintenance phase, focuses on that sustainability of the habits that people have developed. So research also bears this out at 10 years. People who participated in this one-year program, 10 years later, were still 1/3 less likely to develop diabetes. Additionally, people who did go on to develop diabetes had a delay in that development by 4 years. And so remember, we talked about $16,000 a year for the care of people with diabetes. So that adds up for that 4-year delay. In addition, a delay in the development of diabetes also reduces the chances that they would get some of those complications that we talked about, because those occur over time. The program has also shown significant economic results. So the average savings per person per year for medical spend is $2,650. So multiply that out by 88 billion. And we get a pretty big number. We could solve the world's healthcare problems with that kind of money. I also point out the return on investment here. This can be helpful for as you're talking with possible coverage entities that we'll talk about a little bit later. It's important to see that we really see the return on investment pretty quickly within 2 quarters. So that's our background. Let's jump into the building of the NDPP. And we're going to start with the planning and pre-implementation phase. So before you even get started with your lifestyle change program, there are some things that you want to think about. The first is building prediabetes awareness. I mentioned 8 out of 10 people don't know they have prediabetes. So definitely we want to make sure that we're addressing the awareness piece in order for the program to be successful. So we want to get everyone committed to preventing diabetes, and there are 3 key audiences we want to get committed: patients, providers, and the healthcare team. There are some excellent resources from the CDC, which again, I'll include on my resources page later, from the CDC and the Ad Council, that are customizable. You can add logos, you can edit them, really tweak them to your purposes. Or if you have locally developed resources to reach key audiences, that's great too. So our first audience is patients. We want to catch those people, the 8 in 10 that don't know they have prediabetes. We want to make sure they understand prediabetes is a big deal, what it is, why it's important, and we want to make sure that they know that there's something they can do about it at that point. So things like media, posters, letters, social media, radio are all great ways to reach your patients. You probably have some ideas of which of those strategies work best for your populations. So you can use those resources again to key in on the types of outreach that work best for you. For providers, I told you my background is in primary care. Providers do a great job of identifying people with diabetes and connecting them with resources. Prediabetes is a little bit of another story. My typical experience with providers with prediabetes is if somebody has an elevated blood sugar, they may or may not get prediabetes in their record as a diagnosis. And usually the next step is we'll keep an eye on that. So many providers don't know that there's something we can do about it at that point. So presentations at staff meetings can be really helpful to raise awareness about the importance of prediabetes and the ability to intervene before it becomes diabetes. Emails can also be helpful to keep that at the top of people's consciousness. And then academic detailing. If you're not familiar with this term, academic detailing is a targeted education program. So the first step is providers get sort of a report card. It might include how many patients do they have with elevated blood sugars? How many patients do they have with a diagnosis of prediabetes? How many patients do they have who have been referred to NDPP? Now, if there are gaps between those, then that gives the opportunity for targeted education to be able to make sure providers are documenting prediabetes as a diagnosis and are connecting them to the available resources. So it gives the opportunity to then target that, whatever the specific gap is. Last but not least, certainly not least, is the rest of the healthcare team. So again, we want to make sure we're getting everyone committed to prediabetes. And one of the best ways to do that is to have everybody talking to the same sheet of music, singing to the same sheet of music. And so this is your front desk staff, your medical assistants, your community health workers, other members of the healthcare team that might not be directly referring patients, but can speak to the importance of addressing prediabetes. So presentations and emails can be helpful to those groups. Another step before you get your program started is applying for CDC recognition. The CDC recognition is called the Diabetes Prevention and Recognition Program, or DPRP. And they set the standards for the National Diabetes Prevention Program. So they're sort of the accrediting body for NDPP organizations. The standards and operating procedures for the DPRP include this list here. So program eligibility, that slide that I showed you of who's eligible for the DPP, that comes from the DPRP standards. Location requirements. If you are conducting a face-to-face program, you're going to want to look at this location requirements section of the standards. It gives some good information, not only on the logistics of, make sure you have a room that's big enough and make sure you have enough chairs and make sure you have ADA accessible space, but it also talks about if you have a dispersed health system, where might be the best location to set up a program in order to be accessible to all of your population. Delivery modes are also covered in the standards. So there are 4 delivery modes for the National Diabetes Prevention Program. You can have a face-to-face program where participants come in, they meet face-to-face on those weekly or monthly sessions with their coach and their group. You can have a digital program. A digital program people access online, they access the content, and they can interact with the other participants online. So I think of things like academic classes that operate that way, where they have chat functions and things like that. There's also a telehealth delivery. So the telehealth delivery is a little more live interaction, so video or phone interaction with the coaches and the group. And then finally, combination service delivery, which could be a combination of any of those other 3 delivery modes. Staffing is also addressed in the DPRP standards, and there are 3 specific staff that are called out and defined in that in the standards. So the first is the lifestyle coach. The lifestyle coach is the person who leads the program and supports the participants in the program as they work through the program. The program coordinator is the person who oversees the daily operations of the program. And so they support the coaches, but they also oversee those operations to make sure that things are running smoothly. And then the data preparer is the 3rd role, who's responsible for collecting and submitting data to the CDC. Now, when you get started with a program, those 3 might all be the same person, and that's okay. But as you grow your program, you may delineate those roles a little bit more. Training requirements, I'm going to talk about on the next slide. So there are specific training requirements for those coaches. The requirements for recognition are also included in the DPRP standards. So there's sort of a checklist of things that you have to do in order to attain full recognition. And I will also cover that on a later slide. Last on this slide is having a plan for the method of data collection and reporting. So you've got to track the things required for recognition, and having a good plan before you get started of how you're going to collect that information, how you're going to compile that information, and how you're going to report it. I can't emphasize that enough. The data is due to the CDC every 6 months, and you definitely don't want to be waiting until the 6-month mark to find out that maybe your data isn't as clean or as easily organized as you would like. So having a good system up front is important. So as promised, the lifestyle coach training we'll get into a little bit deeper. The very first step with lifestyle coach training is this box on the right. Choose an organization with a signed memorandum of understanding with the CDC for your lifestyle coach training. So they have a list of 10 or so organizations that are approved to provide lifestyle coach training. So you have to pick one of those organizations. Their trainings vary a little bit. So there's about 10 or 12 hours of interactive training. There's usually 8 or 10 hours preceding those sessions. So before each session, there might be an hour of reading or prep work before the interactive session. And then in the interactive session, the coaches actually get to practice. So they learn the facilitation skills, they practice them in those sessions. They learn the motivational interviewing. They actually do motivational interviewing during those sessions, and they learn the Prevent T2 curriculum or the other CDC approved curriculum, and they apply that. So coaches get practice at presenting the material from the curriculum within those sessions. So very interactive. And ultimately, they train the coaches to help participants to make those better food choices, increase physical activity, and lose weight. The last step before implementation is building a workflow for screening, testing, and referral. So you want to plan for how you're going to get participants into your program. And you're going to work with operations and healthcare technology teams to do many of these things. So the first 4 items on here are really taking the data that you already have in your electronic health records and being able to get the people that qualify and get them into your program. So building reports, you can take the qualification or eligibility data that I showed on the previous slide of who's eligible for the program and build reports for that data. You can build alerts. So I have in there ensure uniform documentation, and that helps with the reports. If the providers and healthcare team are documenting uniformly the required data elements that you're going to need to pull for eligibility, that's going to make those reports a lot cleaner. And then you can build alerts, clinical alerts for referral as well. So what I mean by that is you pull up a person's chart and clinical alert comes up that says this person it looks like they're eligible for the National Diabetes Program. Do you want to refer them into the program? Going along with that is the creation of referral templates. So the easier you can make it for providers to refer into the program, the better. And so for referral templates, you may be able to pull in whatever information you need from data fields within the electronic health record. And all the provider has to do is say, is the person interested in participating, yes or no, to be able to result in that referral. So that can help to take people who are in that 88 million and move them into the National Diabetes Prevention Program. The last 2 bullets on here are for our 8 and 10 who don't know they have prediabetes. So plan some point of care screening events. So you can do finger stick tests for fasting blood glucose or A1C to identify people who have those levels in the prediabetes range. You can also engage any level of staff in the risk test. So maybe at check-in, you have your front desk staff hand everybody a risk test to fill out as part of their intake. Maybe you have your community health workers every time they go to the home or go to a visit with a person, they do the risk test with the patient. So there's lots of opportunities to involve the risk tests in pretty low resource ways to be able to then drive the enrollment into the program. All right, so now we're going to move into the implementation phase. So once we've done all of those things, we are going to conduct the lifestyle change program. So this graphic on the left should look familiar to you, that we are going to have our coaches go through these weekly sessions in the first 6 months and monthly sessions in the second 6 months in order to help people change their behavior. So the coaches are going to use their motivational interviewing, their group facilitation skills, and their knowledge of the CDC approved curriculum to conduct these sessions and help their participants meet their goals. The program coordinator at this point is going to serve as a resource for the lifestyle coaches. They're also going to review the evaluation data. So with each session that the coaches coach, they're also going to document, the coach will also document attendance, weight loss or weight and activity level. And then the program coordinator will look over to make sure all of those things have been documented, identify training or operational deficits with that data entry or with attendance. So if they're noticing, people aren't attending the first session, maybe there's something from an operational standpoint that they can do, say start a session 0 to get people excited about attending that first session. The program coordinator can also address awareness and screening, testing, and referral issues. So making sure they're keeping an eye on the awareness and also those things that we covered on the previous slide for the screening, testing, and referral to make sure we're actually getting people enrolled in the program. And then at this stage, the data preparer is going to regularly review the data. So I can't emphasize this enough, that looking at the data as you go along to make sure that things are accurate and that there aren't inputs that are missing is really important when you go to submit for the DPRP recognition. And sort of the example I think of is, a coach puts in a participant's weight is 200 one week, and then it's 400 the next week. The data preparer can spot that and go back to the coach and say, hey, what happened? Was this a typo? What was the circumstance here? In the immediate period, if the data preparer goes back to the coach 6 months later, the coach may not remember what the circumstances were. So correcting those things in a timely fashion can really save you long-term time. Also, in the implementation phase, you want to continue those awareness campaigns to really keep diabetes prevention at the forefront by refreshing education in your marketing. And remember, we have our 3 audiences. So we have the patients, the providers, and the rest of the healthcare team, making sure that we're really getting all those 3 audiences. So conducting regular education with the providers and other members of the healthcare team. You may be at this stage identifying populations that are high risk in order to specifically target for awareness campaigns. So maybe you have a patient population that's a high risk population that you want to do some specific outreach to for awareness. You should also at this stage be reviewing your communication strategies, see what's working, what's not, and then use those resources at the CDC. The Customer Service Center is linked out here. Also, the Ad Council that we talked about will be on the resource slide at the end to be able to refresh those posters, flyers, newsletters, blogs, and all those things that you've got going on to try to raise that awareness. We're going to move into the growth phase. You've got your program set up, you did your pre-work, and now we want to talk about the growth of the program. And the growth includes both the sustainability and capacity building. So the very first step in growing the program is that DPRP recognition. And full recognition really opens the doors for opportunities for sustainability, which we'll talk in a little bit more depth on the next slide. But full recognition is a specific requirement for many engagements, including working with specific payers as well as partners. In order to get full recognition, you have to meet minimum enrollment standards. So you have to have 5 people that completed the program, and they have to have met minimum attendance requirements as well. 35% of the people in the program have to have qualified based on either a blood test or gestational diabetes. The other 65% can come from that risk test. And then lastly, you have to be able to show that your program resulted in a reduction in risk. And there are 3 options for this, and they're looked at the population level. So this is not, each individual doesn't have to meet these, it's overall your program has to meet this. So the 3 options are: number 1, at least 5% weight loss at 12 months. Number 2 is at least 4% weight loss plus 150 minutes of activity per week. And number 3 is at least 0.2% reduction in A1C. So if you can show one of those 3 things, at least one of those 3 things, and satisfy the other requirements, then you can receive full recognition for the program. Now, I mentioned that this is important for certain partnerships. And so sustainability should really be one of the things you're thinking about as you develop the program. Many of these programs, as they get started, are grant funded, but sustainability has to be part of the overall plan because grant funding is not permanent. So we want to make sure we're focusing on sustainability in order to grow and maintain the program. So Medicare, our first one under sustainability, is one of the programs that does require full recognition. So in order to be a Medicare supplier for the National Diabetes Prevention Program, you have to have a fully recognized program. Many of the other types of payers also require this, but Medicare is very explicit about this. You may also be going to Medicaid or commercial plans that you have relationships to see if they will cover NDPP as a covered benefit as well, so that can be part of your sustainability plan. You may have value-based contracts that reward you for prevention of disease, so that may be an option for sustainability. I like to specifically call out employer coverage because employers have additional incentives to keep their populations healthy beyond other payer types. So they want to keep their employees healthier because for self-insured employers, they get money back if their employees don't cost as much for healthcare. So it directly saves them money in order to, or keeps them from spending money if they've got populations that are healthier. So wellness programs like the National Diabetes Prevention Program can be really key for that. In addition, if they have a healthier workforce, they have less absences, they have less injuries. So it can really help them with productivity and costs in that way as well. And then also being able to offer the NDPP as a benefit can help them attract and retain employees. So they have multiple incentives for covering programs like this. Funding through the 340B program is also an option for sustainability. If you're participating in 340B, funds from that can be used to cover the costs of NDPP. If you're not participating, this might be an opportunity to get started with 340B in order to cover the costs of DPP. And then lastly, offset of other healthcare costs. So if you have patients who are using less doctor's visits, less emergency room visits, less hospitalizations, less medication because they don't need those things because they haven't developed diabetes, that can help offset the costs of an NDPP. Additionally, under sustainability, another option is umbrella arrangements. So umbrella arrangements are when you partner with an established program to help with the sustainable delivery of NDPP. And I've got an image here on the right to sort of illustrate this. So you've got a sponsoring hub who has DPRP recognition, and then subsidiaries underneath that. So in this example, I have an FQHC and a telehealth NDPP, but there may be a bunch of different types of NDPPs under the sponsoring hub. And the advantages of participating in an umbrella agreement are that the data is pooled across the hub and the subsidiaries, which makes it easier to meet the requirements for DPRP, even if you have a smaller program. Additionally, it helps with the administrative costs. So things like data collection can be helpful. Maybe the hub already has a data collection process that they're using. So I've kind of harped on data collection and how it can be a nightmare if you don't have a good process. Maybe the hub already has a good process, and so you can follow the same data collection procedures. The reporting also can be a shared administrative cost, so reporting to the DPRP, and then billing also can be completed through the hub, and so that can help with the administrative costs as well. And another advantage to umbrella agreements is that best practices can be leveraged across the umbrella. So different organizations may come up with different ways to do things, and they can all learn from each other and adopt best practices. So that helps all of them be successful. And then lastly is negotiating power. The umbrella agreements can increase the negotiating power for coverage by payers. So if you've got, particularly if you've got a small program, if you can pool your program to show larger capacity with an umbrella arrangement, then you're going to have more negotiating power if you go to an employer or a health plan. Lastly, we're going to talk about building capacity. So as your program grows, you want to think about how you're going to manage that capacity. And here's where I want you to think about who are your team members that you already have. So you want to use your available resources in order to build capacity. So you may already have members of the healthcare team that are participating in the NDPP, but are there others who are not participating who might be able to be leveraged? So nurses, medical assistants. In my program, we use pharmacy technicians as our coaches, the community health workers. So as you think about the different team members that you have, there may be different roles that they can play. So some of them might be able to be coaches. Some of them might be able to participate in those screening events that we talked about, or doing the risk tests. So think about what resources that you have in order for you to build capacity with your program. And then the last thing on here is workforce training. So if you have colleges of pharmacy, public health, medicine, or nursing nearby, these are great opportunities to be able to create some win-win opportunities with those organizations. So all of those students have requirements to be able to do some hands-on education or experiential education. And so by including them in your ability to deliver the NDPP, they get some education, you get to build some capacity. So that's another place that I definitely would look to your communities to see whether there are any of those opportunities available. So we have reached the end of our session. The key takeaways are that prediabetes is an enormous health problem. We saw 88 million people, probably closer to 100 million now that we're have been sitting home for many months. But the good news is that diabetes can be prevented with this evidence-based program, the National Diabetes Prevention Program Lifestyle Change. And so as you get started, really planning ahead, steps to build prediabetes awareness, making sure that you're taking advantage of those resources to build prediabetes awareness, that you're building those processes to be able to screen, test, and refer to get people into the program in order to build that successful program. And then thinking ahead to building capacity and sustainability in order to grow your program. Last but not least, as promised, here is my resource page for you. Under marketing and awareness links here, the first one there is that CDC Take the Test. So I would encourage you on every single marketing and awareness thing that you put out, that the Take the Test is included with that. There's also resources here for the Diabetes Prevention and Recognition Program. The list of the CDC approved training organizations is listed here. So make sure you go there to get your coaches trained from one of the approved organizations. And then lastly, the NDPP Customer Service Center from the CDC has all kinds of great resources as well, if you're having any trouble with anything along the way. I really appreciate you attending today. It's been my pleasure. If you're listening to the recording, please feel free to reach out to me with any questions. My email is listed there on the screen. If you're attending live, we're going to move to the Q&A portion in just a moment. Thank you again.